Good night, everybody. I can see there's on and Andrea, Carolina, Adrián, Julie, Regina, Sonia, Javi. Well, it's been a long day today. After the ceremony of your classmates, as you can see, maybe some of you were there. It was a nice ceremony. I hope I can see you soon. All of you there. Well, today's subject we will be talking about shock, which is quite easy. It's not that difficult, not as solutions, for instance, or acid-base disorders. Shock mainly refers to a physiological state, which is a reduction in tissue perfusion, resulting in a decreased oxygen delivery to all the tissues. It's a condition where circulation is not enough to meet the metabolic requirements, so there's not enough perfusion to salvage every metabolic pathway. Therefore, there's suffering from the tissue and eventually loss, and if the situation continues, death. As you can recall your biochemistry classes, if there's not an adequate perfusion, then the tissues will start making a lack of oxygen, and then they will turn into an anaerobic state, then will eventually produce lactic acidosis, therefore making this much worse. So there's an imbalance between the oxygen delivery to the tissues and the oxygen that is being consumed by them. Shock is that the tissues are consuming a lot more oxygen than the one that is provided. So there's an initial vasoconstriction when the shock initially begins. Then there's a failure in the capillary system. As you can recall, the capillaries have little sphincters, and they can control the pressures in order to sustain the cardiac output. So when we, for instance, there are several types of shock, but we'll be referring much further on to a hypovolemic or hemorrhagic shock, where there's a massive amount of blood loss. Therefore, we don't have anything to pump out, so the cardiac output sees itself jeopardized. And every tissue then falls into hypoxia and becomes in a metabolic state of lactic acidosis, develop metabolic acidosis. And as you can recall, every cell and every transport in the cell becomes diminished and becomes depressed. Even the polarity of the membranes becomes depressed, and then the response of the cell response is to release a lot of digestive enzymes and toxic substances to the circulation, making this condition even worse. And then if the situation continues, well, death surely ensures. So the effects of shock, it depends of the organ, but it will damage eventually every organ. The main organ that will eventually falls to work properly will be the heart. The patient will become hypotensive, and well, the heart itself will fail. Eventually, this will cause or will result in a depressed hydrostatic pressure in the lung capillaries, which will cause hypoxia and pulmonary edema because of low flow in the hydrostatic pressures. The endocrine system, of course, will release hormones such as vasopressin in order to reabsorb every amount of water in order to keep up the fluid and the cardiac output. And if we don't have any perfusion, especially to the nervous system, then the nervous system will eventually suffer. And well, every system, as you can see here, will suffer. So the main thing about shock is that the tissues will be in low perfusion with a lack of oxygen and the eventual lactic acidosis. So every organ will suffer if the shock continues. There are many types of shock, as I told you earlier. The hypovolemic shock refers most commonly as an hemorrhagic shock. You think about it in trauma settings like a car accident or motor vehicle crash, or there's a spleen rupture or a liver rupture and internal bleeding. And then there's a non-hemorrhagic shock, such as burns or a severe gastroenteritis where you have a lot of diarrhea and vomiting. You may develop eventually a hypovolemic shock. Now, there's the other one, which is cardiogenic shock, which is caused as an intrinsic problem of the heart. The heart is not pumping enough blood, and this problem will eventually, it has, let's say it's a chronic problem. Somebody will develop a cardiogenic shock, but before he must have had a cardiac insufficiency, and then he will develop a cardiogenic shock. Or otherwise, if we have a patient that has been involved in a car vehicle crash and develops hypovolemic shock, if we don't resolve this quickly enough, he will eventually develop a cardiogenic shock. Then the pump itself, the heart itself, will not be enough to pump out the blood, and therefore we will lose the cardiac output, and from there everything will get worse. There's the metabolic shock, which is either respiratory or metabolic. These states is where they fall into acidosis. We have the obstructive shock, which is mainly due to tension pneumothorax. Again, we see this in trauma settings, such as cardiac crashes or people that are working on construction sites. Some of them they fall out, or some of the material they work with, they fall over them, and they will develop hypovolemic and obstructive shock. So sometimes these type of shocks can coexist in one person. Now, you see this is the so-called distributive shock, which is divided then in two, which is the septic shock, the anaphylactic, and the neurogenic shock. We'll see this further on, but the neurogenic shock has a special characteristic in which the spine has to be transected in an acute way. So we lose every sympathetic output in the spine. So these patients are not able to keep up with the blood pressure because they don't have any vascular tone because of the loss of the sympathetic output. Now in the anaphylactic shock, well, you see this is quite easy. These patients will overflow themselves with histamine mainly, and histamine causes the vessels to dilate, and when all of your vessels then suddenly dilate, you lose the blood pressure, then eventually you will lose your cardiac output. This is why this is urgent to address. Now the septic shock, it develops first with a site of infection that it didn't, or somebody overlooked at it, or it fell unknown. So the person will develop septic shock eventually, and this means that that infection will cause all of the vessels to dilate because there's some release of histamine and nitric oxide, and these patients will become severely hypotensive. Then there's some special need to use vasopressors. But of course, the treatment for all of these is to address the cause that is originating them. So the hypovolemic, as I said earlier, the common cause is blood loss due to hemorrhage, or it could be due to volume loss, such as severe diarrhea and combined with vomiting. And sometimes it will cause hypovolemic, especially in elderly people. But the most common cause of hypovolemic shock is due to hemorrhage, and it is on trauma. This is the one of the most common types of shock. The cardiogenic, it has to be an intrinsic problem of the heart, either a myocardial infarction or arrhythmia or cardiomyopathy. And as I said before, all of these conditions they have a chronic history of, and so you can make a conclusion and say, okay, this patient had a valvular problem or hypertension problem and developed a cardiomyopathy or hypertrophy cardiomyopathy, and eventually will develop a cardiac insufficiency. Then in turn, if not treated, it will develop a cardiogenic shock. So this condition is a bit more chronic. Now the obstructive, it is due to lungs. It is mainly either all of these conditions are life-threatening. All of these conditions are life-threatening. Either a cardiac tamponade or pulmonary embolism or a tension pneumothorax. All of these are life-threatening. So as you can recall, the cardiac tamponade, it shows up with a Beck triad, which, can you recall which is it?
I don't know how to say it in Spanish, but one of them is ingurgitación jugular.
Yes, the triad is, as you said, is jugular ingurgitation, right? And it has your patient is hypertensive, and the other one is that the cardiac sounds, there are no cardiac sounds. You don't hear anything when you with your stethoscope. You can't hear anything. And the tension pneumothorax, you have to suspect it. The patient has been involved in a severe accident, and it shows with a low saturation, oxygen saturation, very low, and you can see there's asymmetry in his asymmetry in his thorax. So you can see one thorax is elevating while he breathes, while the other one is not elevating properly. And when you put your stethoscope in a tension pneumothorax, you cannot hear any breathing sounds on the affected side. Plus, if you make a percussion on the affected side, you will hear it tympanic. Can you recall this term, tympanic? The normal sound that you have to hear when you make percussion to a patient is a pulmonary. Can you see the difference? When you make percussion to these kind of patients, you will hear like a hollow sound. And besides, you will see deviated. The trachea will be deviated to the other side of the affected side. I mean, the affected side will be full of air, and it will be pushing the trachea to the other side. And also, we can see some jugular ingurgitation as well. These two are life-threatening on a trauma bay, and you have to address them quickly, in minutes, otherwise the patient will die. Now, as it is to the pulmonary embolism, you have, okay, here, I'm gonna say this to you. You have to suspect from a patient of pulmonary embolism. The first cause that originates a pulmonary embolism is a deep venous thrombosis. You already read an article about it. So you have to suspect from those patients which are fat, or the surgery has been long enough, or without mobilization of lower extremities, or the patient is taking some medications, or the patient has a condition such as cancer, which is per se thromboembolic factors. You have to watch out for the thromboembolic factors. One of them, which is very common, I'm going to put it right here. Can you see all of those patients that are very obese, and they tend to have these kind of surgeries such as gastric bypass in order to lose weight? This surgery usually takes very long time to perform it. So we're talking, if it's fast, it's about between 4 to 6 hours. Some of them, they take about 8 to 12 hours to perform a bypass, a gastric bypass. So you have a patient which is obese, then you have the immobilization factor, such as a gastric bypass in the surgery. So in these kind of patients, you have to assume that most of the time they will develop a deep venous thrombosis. Therefore, you have to start immediately in these kind of patients anticoagulant. Can you remember which one? Can you remember we talked about?
Maybe heparin?
Yes, very good, very good. Either one that you have, either regular heparin, or you can use low molecular weight heparin. Most cases, we use enoxaparin. Right before the surgery is over, 24 hours later, we start these patients on enoxaparin, on anticoagulant, because we want to prevent they will develop a deep venous thrombosis, which eventually will develop or may develop a pulmonary embolism. But as it goes from shock, these two are the conditions that you will see on a trauma bay, and you have to address them right there and there, otherwise the patient's gonna die. Cardiac tamponade and tension pneumothorax. Remember these triad, and remember the tension pneumothorax. I'm going to show you next Sunday some x-rays showing tension pneumothorax, which, by the way, you are not supposed to wait until that patient to get an x-ray. you have to suspect it always clinically. If you see an X-ray of a tension pneumothorax, remember this, you're watching an X-ray of a dead man. Is this clear?
Yes, very clear.
And it's very, very easy to handle them. You can solve that within seconds, and you save a life. So as I told you before, the neurogenic shock, it has to be a spine transected acutely. So aside from the fact that the patient is not going to be able to walk from the point that the spine had been transected down below, there's another condition that is very serious. Can you remember the thoracic segment of the spine? The thoracic and the lumbar segment of the spine is the one that has all the sympathetic information. So if the spine gets transected, then all of the sympathetic information is lost. Therefore, these patients will arrive and there's no apparent blood loss, so but they cannot meet, they cannot get a sufficient blood pressure. And you infuse them as regularly, your 2 liters of saline solution or Hartmann solution, and the pressure is still way down. But since they don't have the sympathetic input, they don't develop the reactive tachycardia. Am I putting this clear?
Yes.
All right, we see this, the anaphylactic shock. That's why you always remember to ask every patient, all of your patients, you don't know what they are allergic to, so you have to ask all of the time if they're allergic to some medication. If they are, of course, obviously, you are going to avoid those medications. But let's assume that the patient didn't know that he was allergic, let's say, to quinolones. And you give him a quinolone, and he's starting making rash, he's starting to cough, his eyebrows just start to get swollen. You have to treat this immediately, because these kind of patients release an enormous amount of histamine, and histamine will cause every vessel to dilate, so the blood pressure will get lost and your cardiac output will suffer tremendously. So what will you do in this case? You have to ask very fast. They will arrive to your office.
I would give them.
And you write down your answer to this. Let's say you ate some shrimps and you started to cough and you starting to have trouble breathing and you have rash all over your face. Yes, Adrian, very good. You give steroids. What kind of steroids? Immediately, you have to shock this patient right there and then. You can give an yes, congratulations. Okay, you give the short-acting steroid, and it is short-acting, but it acts very fast. So you give that person dexamethasone, 8 milligrams, and if you have some antihistamine, such as, I don't know if you heard about avapena. Have you heard of it? I'm sure you did. Well, you prepare your shot with these 2 solutions in a syringe, and you shot the patient. Okay? So you stop the reaction. And of course, you explain the patient, well, you didn't know you were allergic to these kind of medications such as quinolones. So from now on, you will avoid these medications for your entire life. Very good. Now, the septic shock. This is very interesting because it develops careful with your diabetic patients. I told you earlier, and I will tell you for the rest of the course, if you have a diabetic patient, you will assume that the patient is infected until proven otherwise, okay? So you have to find that out. If you have an infection, you have to look for it, otherwise it's going to keep developing, and it will develop a first sepsis. Then if the sepsis continues, it will develop a septic shock. Of course, the treatment to this is to treat the main cause. So if we don't find any site of infection, we have to keep looking until we find it. Otherwise, the patient's going to die. What happens here is that the pressure gets lost. So you have a patient that is not responding to your crystalloids. His or her blood pressure is very low. The cardiac output starts diminishing. Plus, you have the fever, and you have the leukocytosis, and you have the reactive C protein way too high, and all of the infection and inflammation markers way too high. So you have to find out the site of infection, and if you find it, and if it's possible, you have to make a culture of it, because some of these patients, you will see that they will start on empiric treatment. Have you heard of it? Empiric treatment?
Isn't it antibiotic you give first before you know what's the infection? But
exactly. You start in some broad spectrum antibiotics before you do know the cause, but more specifically before you know the microorganism that is causing this. For instance, you see this leg over here? Let's assume that this patient is a diabetic woman, that she doesn't take her medications and she's not on a diet, and she arrives to the emergency department with this leg, plus she has fever of 39.5 Celsius degrees, and this leg is swollen, very tender, very painful, and her blood pressure is 90/50, and her heart rate is 110. So, first, I'm going to open up another. First, you must have an infection, right? Then you have the SIRS, which is it is a inflammatory response syndrome, okay, which is you must have either fever or low temperature, either above 38 or below 35. You must have high white blood cells above 12,000, or very low blood cells below 4. Can you recall this? And your blood pressure has to be low. The systolic pressure has to be lower, right, than 80. Or the diastolic pressure has to be below. Can you remember this? Below 60? Have you heard of the terms? First you have an infection, right? Let's say you have a throat infection, okay? So you have a throat infection and you start with fever, and you take a blood sample and you find out that you have your white blood cells in about 8,000 or 10,000, but your blood pressure is not dropping because you have your immune system that can fight off the microorganism until you start your medication. But let's assume that this situation continues. In a diabetic patient, this continues. So he has an infection, then he develops a syndrome of inflammatory response syndrome, then he will develop sepsis, which is the lower of the blood pressure, but it responds to crystalloids. And then we have shock. Now, the septic shock, it means that the blood pressure is not responding to the normal therapy, which are crystalloids. Okay? So if you have this, then your patient is in shock due to an infection. What you need to do here is to treat with vasopressors, such as vasopressin. Okay? And you have to treat the cause, of course. And norepinephrine. Okay? So, we've already seen the type of shock. Of course, there are degrees of shock. You have the mild, the moderate, or the severe shock. Especially in the hypovolemic shock, we have degrees. We have 1 through 4. And it depends on the amount of blood loss that the patient has. If he has lost beyond 1,500 milliliters, then we're talking a grade 4, which is very severe. So what's going to happen? Well, as I told you before, this patient is not going to have any tissue perfusion. He's going to be demanding way too much oxygen. And of course, if there's no perfusion, then there will be no oxygen to provide to every tissue. So if he doesn't have any perfusion, how do you think the patient is going to urine? Well, he's not going to urine anything. So the urine output will not be normal, even a severe shock. This is mild, but if we're talking about moderate to severe shock, then as you can see, the patient will start urinating a bit less, his heart rate will start increasing, and his blood pressure eventually will fall. Careful with this. These are signs that your shock is evolving. Now, in the severe shock, your patient is not responding, it's not urinating, it has tachycardia, it is hypotensive, but most of all, it is not responding to any crystalloids. Then you have to use vasopressors in these kind of patients. Otherwise, you don't have any cardiac output to sustain your patient alive. So we have stages. Well, some of them, they will arrive, unfortunately, in severe shock, especially those diabetic patients. You have to watch out for them. They are like, when you see these kind of movies that you see a man that puts a bomb into his chest and is running across the hall, well, you think diabetic people like this. They are a tic-tac bomb, so you have to watch out for them. So in the initial state, the body switches to an anaerobic state, so it will start forming lactic acid. There's a state in which we can compensate in an attempt to correct this metabolic consumption of oxygen, but it lasts a few hours. Then the progressive state is already decompensated. The tissues are needing a lot more oxygen than they are being provided. And in order to see this, there's a test that you can perform very easily. Do you know how to perform a gasometry? When you perform a gasometry to pull out the arterial blood gas, you punch into the radial artery or the humeral artery or the femoral artery. But sometimes you can do this in the venous part. You pull out the venous because you already know that the venous blood is non-oxygenated, right? So you must have a percentage value of oxygen in this test. If you see that your oxygen is way too low than the normal settings, that means that your tissues are consuming a lot more oxygen than the one that is being provided. This is an indirect analysis to determine if your patient's still under lack of perfusion. Is this clear?
Yes. So wait, one second. So the venous gasometry is supposed to have a low percentage of oxygen, but if the patient is in shock, it will have an even lower one, or even though
yes,
it's normally low?
Yes, that's correct. That's correct. I mean, if you pull out your blood, instead of punching the arteria, you do it into your vein, you will normally find a lower oxygen percentage comparing to the artery. Is that correct? It's normal.
Yes.
Yes, it's normal. But if you find that value, the oxygen percentage, you will find it very low. That means that your patient is in low perfusion.
Are there any numbers we can guide ourselves with? What's very, very low? What's the limit?
Well, the normal amount of oxygen in your blood is between 75 to 80 in the venous part. As you can recall, in the artery it is way different. You go to 90 to 95, right? So it is normal to have this value in your venous part because your venous system is blood that is let's quote non-oxygenated yet. But if you find it below that 75, that means that your patient, it is consuming more oxygen than the one that is already being provided.
So the limit is 75. As long as they have less than that, you can suspect of shock?
Yeah. Well, the shock, you will suspect it clinically. But there's a vague analysis to let you know that your patient, it is in low perfusion. You perform this kind of test. It's very easy, it's very low cost, and the results are very quickly, within minutes.
Okay, thank you.
So when you when you are asked that you perform this kind of test, then you will know why. Then you will see that they're looking for tissue perfusion. So the early signs, which is a compensated stage, your patient is anxiety, is irritable, it may be looking pale, with a beat or a tendency to have a heart rate elevated. Tendency, not tachycardic, but tendency. Let's say 98, 96. It is within the normal range, but it's the tendencies to have it, like tachycardic, but not quite. So these the early signs. We may look, or they can be overlooked. So we have the late signs. That's when we see patients in the emergency department with late signs, decompensated. The patient is confused. His body temperature, it is way too low or way too high, depending on the kind of trauma or the kind of shock that the patient has. The blood pressure it's very low. He has tachycardic, and he has irregular respirations. Watch out for this. Now, we can make an intervention right in here in order to be too late for it. If you see this, you have to act quickly. Let's assume that we're talking about an hypovolemic shock, and you see a patient like this. It is cold, it is pale, it has low blood pressure, tachycardic. Well, I think it's kind of obvious, don't you? You have to find out the place where the patient is bleeding and stop the bleeding and replace the blood cells with transfusions and infuse him volume with crystalloids. And then once you do that, you will reverse this late signs of decompensated shock state into a normal state back again. Let's assume, okay, you find out a patient which is diabetic and has a urinary tract infection over the last 10 days, and you find them in the emergency department like this. What will you have to do in order to reverse this to a normal state? Well, you have to treat the cause. You have to find out where the infection is, make a culture if possible. Always remember this. Make a culture if possible, and start this patient immediately on empiric antibiotic therapy. And of course, you have to address the metabolic acidosis. You have to hydrate your patient, keep the blood pressure up, and this will eventually lower his tachycardia, and you will return this patient to a normal state and compensated state. So as I said earlier, by just knowing the story of your patient, knowing what happened to it, and making a physical examination, a proper physical examination, you're halfway there. You already have half of your diagnosis. Then you make your lab test, your blood work, and they come back with it, and then you already make your whole picture, and you can start treating. If you don't see this, or anybody else didn't see that there was something wrong with these kind of patients, then they will advance or progress to a irreversible state, which is death. There's the kind of shock that nobody find out what was wrong with it, or they didn't act, or they act very late, and the patient is in severe shock and will eventually die. So you can act by looking at this. It's not very difficult to look at these clinical signs, is it? No? If you see this in your emergency, it isn't. So I told you, this subject is kind of obvious, and it speaks for itself. So it depends on the cause, and you treat the cause, and then your patient will be fine. Now, there isn't always all the time that simple, but you have to suspect it first. Questions so far?
How likely is the patient to die? Like, if you don't suspect it, they will die. But if you suspect it, how, like, is there a big chance that you can reverse it, or do they normally die, or?
No, of course. Most of the times, when you find a patient or their family take them to you in the emergency department, is because the patient is not well. They arrive in these kind of conditions with late signs. So you see them, and in time you make your timeline of events, and you say, okay, this patient, let's assume it's a septic shock. Okay, the patient is diabetic, he must be infected, and the patient hasn't eaten since 3 days ago and start feeling dizzy and had fever. We gave him acetaminophen for the fever, but he didn't get well, and now he's not. He hasn't gone to the bathroom in the last 24 hours, and he's falling asleep all the time. Okay, so you say, all right, so you have already half of your diagnosis there. You make your physical exploration, and you see him with a blood pressure, let's say 80/40 on a heart rate of 120, and his temperature is 39.5 degrees. So you say, this patient is in septic shock. I gotta find where he is infected. So you make your blood work, and you start making a urine sample exam, and you take your culture, and you start immediately on antibiotics, broad spectrum antibiotics, and your patient's going to get well. Let's set another scenario that you have a 28-year-old male that just had a motorcycle crash accident. He was projected from his vehicle. He was running about, let's say, 150 kilometers per hour. And you find him with, he's very pale, he's cold, he's not responsive, his blood pressure is, say, all right, let's say 40/20, and his heart rate is 160, and his temperature is 35 degrees. What would you do up to this point? What kind of shock do you have in front of you?
Hypovolemic shock.
Exactly. What do?
You have to stop the bleeding and infuse, like,
of course, very good. Yes, yes. So you see, it's kind of obvious, right? You find out what happened to the patient. All right, you make your timeline of events. You check a thorough physical exploration of your patient, and you're halfway there. Then you request your laboratory test, and when they get back, you already have the whole picture to begin to work with. Okay?
And only... Oh, sorry.
Yes, yes.
Okay, I go first. Okay. only septic shock comes with fever?
Yes.
Okay.
Yes. Any other questions?
Yes.
Adrian, yeah.
Yes. For example,
Adrian.
in the accident, I know it's in a hypovolemic shock, but it also could be an obstructive shock because the patient maybe have a pneumothorax, right?
Yes.
I don't know.
Very good. Yes. Yes. They can coexist at the same time. You have to look for it. But then
Okay.
again, your physical exploration will tell you what does the patient have.
Thank you.
No, you're welcome. So, how are you going to follow these vital signs? Well, of course, you're going to plug in the monitor to the patient, or you're going to take your patient to the intensive care unit. Intensive care unit, it's because they have the monitors on the patient 24 hours a day. So you are watching the blood pressure constantly, the heart rate, the respiratory rate. You're watching how much the patient is urinating, and you can take blood samples every now and then, almost when you need them. And you gotta have all of your image work right away, either if you need x-rays, ultrasound, or tomography. But you don't use any tomography if your patient is hemodynamically unstable, okay? If your patient is in severe shock, you don't do this kind of test, all right? This kind of test,
Could you repeat?
the patient has to be hemodynamically stable. Sorry, Adrian, you were saying?
I don't understand that. Could you repeat that, please?
Yes, look, you do all the routine work, right? Your physical exploration, but sometimes you may be needing some test to assist you and make a proper diagnosis. As when we refer to the CT scan attack, you will never perform or order a CT scan on a patient that is hemodynamically unstable, because the patient, the patient may die into the way to the CT scan. Okay, you may perform a portable X-ray or an on bed, the ultrasound, and that's fine because you're not moving the patient and you're right there with him. But taking him to the CT to perform a CT scan, it requires time, and valuable time that you have to save, and first you have to stabilize your patient. You will be needing some sort of special monitoring if your patient requires. For instance, let's say you have a patient in septic shock, which is 80 years old. All right, you have an 80-year-old patient that you don't know how much volume you are willing to infuse him, right? You're allowed to infuse him without causing him any pulmonary edema. Are we clear so far? So you need another measurement to tell you how much volume you may be able to infuse, and this is by measuring the central venous pressure. The central venous pressure, therefore you need a special catheter, which is a jugular catheter or subclavian catheter, that it goes right on the right atrium. When the vena, when the cavas, they get together on the right atrium, and the catheter is placed right in there. How do we measure that? Because we already know that physiologically speaking, that chamber has to have no pressure at all. The pressure in there has to be very low comparing to the left side. So if we have low pressure in there, that means that we can still be infusing volume because that pressure in there, it is low. I'm talking about 0 to 5 centimeters of water, which is the normal pressure. Okay? Sorry, 5 to 10. 5 to 10 centimeters of water, that's the range of normal pressure in the right atrium. If you have below this value, that means that your patient is dehydrated and you can still infuse a larger amounts of volume in that patient. But if you measure a pressure that goes beyond 12, that means you have to be careful. You're not allowed to infuse any more volume, otherwise you're going to cause him for sure a pulmonary edema. Okay?
This also applies to a patient that has, like, it's an adolescent or someone younger, right?
Yes, yes, of course. Okay. It is, you measure the central venous pressure when you want to make sure you don't want to cause any pulmonary edema. So you need to measure that carefully. But you have to install the catheter first. All right, this over here, that's another kind of catheter, and you will find it in your books as abbreviated as WP, which is called wedge pressure, and it measures indirectly the pressure of the pulmonary artery. And you do this especially in patients that have been or had a cardiac bypass. So you need to have measure both pressures, so much as the pulmonary pressure, which has to be below 12 mercury millimeters, and you have to measure your central venous pressure that talks about the right side of the heart. But these are, then again, you have to install a special catheter first, and then you have to do your monitor. It depends on the patient. Of course, you have to measure how much the patient is urinating. You have to measure on clinical basis your blood gases. In your blood gases, they will tell you how much lactate is that person producing. And here again, your mixed venous saturation, that's when you perform a blood gas on the venous system. So, sorry, I set a value earlier of 80 through 75, but the normal value is, it ranges from 50 to 70%. Below this, you're talking about low perfusion. Of course, you have to treat the cost, whatever it is. Otherwise, it's not going to improve. The shock itself is not going to improve. Once you treat the cause, your cardiac output will improve. Therefore, your tissue perfusion will return to normal basis. So overall, you have to increase your blood pressure, to increase your cardiac output, and eventually it will increase the oxygen delivery to the tissues, and the tissues will themselves will demand a lot less than they were needing them. You have to check first your airway, such as when Adrian says in a trauma patient, you have to go through your ABCs, the airway that is clear, that the patient is breathing, that means he has breathing symmetrically speaking. You hear breath sounds on both sides of the hemithoraxes, and your circulation, that means your perfusion, it is adequate, and that ensures an optimal oxygenation and an optimal cardiac function. In order to reestablish the blood pressure, you already know you use crystalloid solutions such as normal saline or Ringler lactate, depending on the situation, or Hartmann solution. As I said before, colloid solutions, especially in shock, they are forbidden. There are some cases in which you use albumin in order to avoid edema, and you may as well want to use blood transfusions, especially when your shock is a type of hypovolemic and hemorrhagic. And that will make sure that the oxygen is being delivered throughout the entire body. You can see if your patient will respond rapidly. If you infuse, can you recall the IV bolus between 1/4 and 1/2 liter of fluid? The patient will respond rapidly. If he falls over to be worse again, then we're talking about a transient responder that he got better and then got worse. Then you have to making a transfusion, or you're talking about a neurogenic shock, or your main cause is being latent. If your patient is bleeding, that means that the patient is still bleeding. And then there's the kind of patients that they are non-responders. That means your patient is in an advanced stage. He's not responding to the initial resuscitation measures. Therefore, you have to expect the worst and act quickly. In these kind of patients which are non-responders, most of the times they're in pretty damaged conditions or have an underlying disease aside from the one that is showing up. I said in septic shock, if it doesn't respond to crystalloids, you need to use vasopressors such as vasopressin. Dobutamine, it helps to increase the cardiac pump, and you may want to use as well norepinephrine. Of course, if the patient needs antibiotics, you give him antibiotics until you have the result of your cultures. If you need some sort of a special analysis, such as central venous pressure or the wedge pressure, you need to install the catheter. If your patient is, let's say, is not breathing, or it has or developed a respiratory acidosis, well, you may want to intubate him. And if the patient has too much pain, you give him something for the pain, etc., etc. That means you have to act accordingly. This is not the rule. These are just some observations that the objective of this is not for you to learn what else can you do, but to think from the source. If you find out what the source is, then you treat the main cause. And in order to treat the main cause, you can do whatever. It will be accordingly to your patient or your patient status. Let's assume, for instance, that your patient is vomiting, severely dehydrated and with diarrhea. So you make cultures, you start him on antibiotics, and you give him medications to stop the vomiting, or perhaps you want to install him a nasogastric tube in order to try to stop the vomiting. You see what I mean? So when you say other treatments, you will use whatever you think necessary for that patient. Okay? Any questions? So I told you this was easy. So your goal is to get your patient back alive and well. So you're going to be measuring his blood pressure, his mean arterial blood pressure ranges from 65 to 90. That will ensure a optimal cerebral blood flow. You will have a central venous oxygenate concentration. That means your venous gut blood work of above 70. That means that the patient is not requiring that much oxygen, so his tissues are well perfused. And his urine output has to be at the very least, at 0.5 milliliters per kilogram per hour. That will ensure that your patient is well hydrated and is keeping enough blood pressure. Therefore, your cardiac output is sustainable. From there, these are your initial measures that you have to work with it, and you have to do whatever it takes to get these measures. So, recommendation is to look for early signs of shock, and you get this by your timeline of events. You make your physical exploration, then you have your half diagnosis there. If you see him with shock signs, then monitor your patient properly and follow the above rules, which is see how much he's urinating, check his mean arterial blood pressure, watch out for lactic acidosis, and start treating the cause. Basically, that's that.
What's MAP?
What's what?
MAP, the initials MAP.
Okay, this is the mean arterial blood pressure. Can you recall the formula? Mean arterial blood pressure.
2/3 of diastolic and 1/3 of...
Yes, yes, that's it. Yeah, that's it.
Okay.
So the best way to approach your blood pressure, you don't say, all right, the patient had, at first he had a 120/70 and then he fell out and he had 100/50. So instead of saying this, especially on the intensive care unit, they talk about mean arterial blood pressure, which is the calculus, and you take a value of it. So if you say your patient has a mean arterial blood pressure of 80, you say, okay, that's fine. I assume that that patient had a normal blood pressure, right?
Yes.
Any other questions? See, this is very important. In septic shock, you start on antibiotics. You do not wait for the cultures to be on. but you take the cultures. And in the meanwhile, you start your patient with empiric therapy, and when your cultures get back, either you may stay on the same antibiotic accordingly, or you may switch it to the most proper one. So as I said to you, this is easy, wasn't it? It's kind of obvious, right?
Yes, yes it is.
All right, so I'll see you Sunday at 11.
Yes.
Okay, I'm going to show you next session some X-rays of simple pneumothorax and tension pneumothorax, and some images of a central venous catheter misplaced and placed correctly, so that you can distinguish between the two of them.
Okay, great.
Okay. Yep, cool. Thank you.
All right, well, thank you. Have a good night, rest, and I'll see you tomorrow.